Fun fact about me, I might need to put these on. Fun fact about me, those of you who know me probably know my fun fact, that I love Disney and my dogs. But I don't think that's news to most of you who know me. But if you don't, that's my fun fact. So like Dr. Quazzo said, we're going to talk about deep venous disease. Let me see if I can figure out this clicker. I might need help. Got it. So a little bit anatomy, pathophysiology. If you're talking about deep vein disease in the pelvis, you have to talk about pelvic congestion, obviously most common in females, dilated ovarian veins due to pregnancy and hormones leading to valvular incompetence. Talked a little bit yesterday about May Thurner in the talk last night at dinner. Dr. Lassar covered, or Dr. Harris covered. Compression of the left common iliac vein by the right common iliac artery, and then nutcracker left renal vein compression. For the purposes of this talk, we're going to focus on the iliocaval system. And May Thurner. Vic's approach to venous disease, basically we do a full clinical workup by the provider. That includes assigning all patients that present for a venous workup with a SEEP score. Based on that SEEP score, the diagnostic ultrasounds are ordered, which would be either a lower extremity venous reflux, or SEEP3 and higher would get an IVC iliac vein duplex. And then we also, if patient symptoms indicate, order the pelvic ultrasound, which includes evaluation of all those deep pelvic veins. But like I said, we're going to focus on the iliocaval duplex part of this today. So May Thurner is described as compression of the left common iliac vein. Most often see or can see retrograde flow in the internal iliac vein. Patients who we have also seen this in our lab now that we've done a ton of these. That patients who present with common iliac vein compression and they've had it for a while also can develop post-thrombotic disease from that constant compression. But we see it anywhere along the iliocaval, the femoral iliocaval tract, not just at the caval confluence. One of the things that would indicate they would need an iliocaval duplex, like I said, we evaluate their symptoms based on the SEEP score and order that. If you're just doing a lower venous, if maybe the lower venous was all that was ordered, maybe you were just doing a DVT exam in a patient, but you had asymmetry of the common femoral vein, that would indicate that you would need to go higher. In our lab, we work really close with our providers, and sometimes we will just continue to go higher. They expect if we find something abnormal, then we would just give them a call. Hey, their common femoral veins were abnormal. I went higher, and they would place the order that we would need for documentation. It kind of, working very closely with the providers really helps speed up that process taking care of patients. Patients with a history of DVT or reoccurring DVT, hypercoagulability, and all these other things that you would see that would be an indication to go higher into the pelvis. One of the limitations or contraindications for doing the iliocable duplex is a result of physics, right? But we know that we have to battle obesity, the depth of the vessels, all of that. One of the limitations of ultrasounds is depth, right? So in our lab, I try to guide our providers that if they have a BMI of greater than 45, the ultrasound is probably not going to be diagnostic. And we'll kind of say they probably need to go on to other imaging. But in the hands of a skilled sonographer, a patient with a BMI of less than 45, you can get really good imaging and diagnose this compression fairly easy. When we first started, I had always done imaging in the abdomen of the iliac veins, doing DVT studies in my career, but about 10 years ago, Dr. Lasar said, well, no, not 10, probably about 7 years ago, we're going to start really looking for May-Thurner or iliac vein compression, because Dr. Harris is going to talk more about why it really plays a role in a lot of these patients. You can't sometimes just fix the lower leg if they have true outflow obstruction. So you kind of have to fix that as well in a lot of these patients. So at first I was very skeptical. We're not going to be able to really see a lot in the abdomen. Veins are harder to see in the abdomen. Arteries are more pulsatile, easier to follow. But as we've been doing this and gained a lot more experience, I've had to kind of eat those words. Over my career, I've had to eat a lot of my words. Where I said, no, doctor, surgeon, we can't do that. And then, yes, I think you can. And with a little bit of pushing and a little bit of guidance, and wanting to get that information for your patient to give to your surgeon, you have to, in the hands of a very skilled sonographer who really wants to get good images, you can really do well in diagnosing these patients with compression and get really good images. But you have to use all the tricks in your tool belt that you know about ultrasound. We ideally want these patients to come in the morning. We tell them to take something the night before to reduce bowel gas, empty their bladder. Sometimes that bladder being too full can kind of compress those iliac veins. You can raise the head of the bed a little bit. A lot of our older population like to wear, we used to call them girdles. I don't know what they call them now. My mom wore a girdle every day of her life. I think we're a little bit more let it hang out anymore, but there are spandex out there. Some of these older women, we have to kind of remove those restrictive undergarments. Then you used your curved probe that gives you the better penetration. Tish, yesterday in our breakout session, talked about sometimes turning the patient supine to get some of those images. You can overcome a lot of the obstacles and get good images, but we start at the common femoral vein. And I think one of the key things to this, even in some of the patients that maybe you can't overcome the physics of it, if you really pay attention to your waveforms at the common femoral vein level, that asymmetry from right to left can really tell you a lot. Even if you can't get up into the common iliac vein, it can tell you, okay, maybe I wasn't able to image it, but this person has abnormal waveforms right to left. So then we would image the entire iliocaval tract using grayscale, color, pulse. One thing I wanted to also, common femoral vein reflux of greater than 2,500 seconds is a very good, at the common femoral vein, is a very good indicator of proximal obstruction. So we use 1 second as, yes, this is reflux in the deep system, but if you get greater than 2,500, that is a very, very good indicator that you have compression or obstruction proximal. This is just showing the difference from right to left. This is very obvious here. It can be sometimes more subtle. So going from the right to the left immediately, instead of going all the way down the right leg and then all the way down the left leg, you might forget that it was a little bit subtle. So going from the right to the left and comparing it is very helpful that I've found. And of course, you're going to evaluate each segment of the external iliac and the common iliac vein with grayscale, color, and pulse wave. Because we use velocity waveforms, velocities in our criteria, typically you don't need to use an angle correct when you're imaging veins, but because we are using the velocities as part of our interpretation criteria, you will need to make sure you angle correct imaging these iliac veins. So in our lab, these are the reduced vein diameters that indicate compression, so less than 6 millimeters at the common femoral vein, 7 in the external, 8 in the common. And I tell the techs, as you are taking your images, you need to make sure that those diameter measurements are getting larger. If they stay the same, maybe it's not greater than 60% narrowing that they would find on IVUS, but maybe they still, maybe they're in that, well, do they need a venogram or not? If you get the same range of diameters going up, you know, that still may be this patient, as well as their clinical presentation, may benefit from a venogram. So the vein size should get larger as you get towards the IVC. Again, just in an artery, you will get post-stenotic turbulence after an area of narrowing. So you'll get higher color flow, you'll get higher velocities from one segment. You'll see color aliasing. Sometimes you'll get continuous flow pattern. You cannot hang your hat on just one of these. So we use a combination of diameters and flow velocities. So when do we call it positive or consistent with compression? When the lumen is visibly narrowed, when you have a velocity ratio from one segment to the next of greater than 2.5. You cannot totally rely on those waveform changes, but you can pretty much predict which patients probably need to go to venogram and which patients maybe not. Letting the provider put that together with their clinical picture. You can also have extrinsic compression anywhere along the iliocaval tract, not just a result of May-Thurner, but you could have enlarged lymph nodes causing compression, tumors. We've seen a lot of patients that had swelling in one leg, thought it was deep vein compression. Turned out you saved their life because they had a mass in their abdomen that was malignant. So those waveform changes in the leg can really indicate more than just looking for DVT. Duplex ultrasound in the hands of a skilled sonographer can determine which patients need to go and which probably wouldn't benefit. So real quick, I have one case study, 38-year-old female, reported leg heaviness, pain with ambulation in her thighs, burning in her feet. Provider assigned her a SEEP score of 3, which is edema. There was a lower extremity venous reflux. We did not order an IVC iliac vein on this patient, which Dr. Lassar would fuss about, but we didn't. She also had autoimmune disease. So the lower venous duplex findings, she had right deep vein insufficiency, left common femoral and GSV insufficiency. The APP recommended at that time an IVC iliac vein due to finding deep reflux on the lower extremity venous. We have since changed our protocol, and they pretty much order both tests when they have a C3 score now, with a BMI of less than 45. No visible varicose veins, but she did complain of heaviness in her legs. So we did the iliocaval duplex, and this is what we found. We found a size in the right common iliac vein of 8.4, which you can see those diameters obviously didn't get larger. We also had a velocity ratio of 4.9. So that satisfied both of the criteria. Now on the left, you can see the vein size was much smaller, 6.2 and 4.7. So she had not a ratio. So that's why I say you can't just hang your hat on just that ratio. You can't hang your hat on just that diameter. You have to kind of combine your criteria. But on her ultrasound, you can see the visible narrowing there in her common iliac vein. You can see it, the distal common iliac vein, it was 12.2 millimeters, going up 8.4 and 8.1, giving you a velocity ratio of 4.9, going from 13 centimeters per second to 62.5 centimeters per second. So that was the right. Over on the left, it was very much visibly narrowed there, and going with, at 4.7 millimeters, but the VR was only 2.2, but obviously visibly narrowed, consistent with left common iliac vein compression. This patient went on to IVUS and venogram, which we're going to show, Dr. Harris is going to talk about. So her diagnostic findings, she had significant compression, not just in her iliac veins, but also of her IVC. This surgeon treated the bilateral common and external iliac veins with a stent and extended into the IVC as well. She came back, her stents were patent on ultrasound, reported a drastic improvement in her symptoms. She had a little bit of post-op back pain, which is common, placed on Xarelto. We'll see you in 6 months, everything looks great. She came back in 6 months, still complaining a little bit about swelling at the end of the day. Her symptoms were much improved, but still complaining a little bit about swelling, but overall much improved. This is my shameless plug I'm going to end this presentation with. This is my daughter. Go to her website, check her out. This is my shameless plug. This is another one of my fun facts. Thank you.
So again, I'm Will Harris. I'm one of the vascular surgeons. Fun fact about me, I was a musician and a pilot before I went into medicine. So I love music and I love aviation, but in order to make a small fortune in aviation, you have to start off with a large one. So I had to go into medicine. So I'll talk about deep venous management. We'll get into that in just a second. But first, I'd like to cut to Dr. Lasar, who's waiting patiently live, about to give us the most about in-depth presentation about deep venous management we can possibly get. Chris, can you hear us?
Are we ready to go?
Yes. Let's see. Chris, can you hear us?
Hey, Will, I can hear you great. How are you?
Great. And we're live back in that room. We can see you and Aaron
Excellent.
patiently waiting, and we're going to get going. So.
All right, so let me go ahead and present this case. This is a patient that you know well, Will. You did her original ultrasound for the insurance portion of this, which is sometimes challenging for patients. But she's a 41-year-old female who has had problems since her high school years. She's had trouble with discoloration of lower extremities, veins that broke. She's been having a lot of problems, most recently with pain, pressure, heaviness, achiness of the lower extremities, significant swelling, worse at the end of the day. She's had multiple ligamentous tears in shoulders, knees, wrists, and is likely has a clinical diagnosis of Ehlers-Danlos, the hyperflexibility portion. Very different from Ehlers-Danlos, the arterial side. So they're very different diseases. And she is presented to our clinics for evaluation for May-Thurner obstruction, and her ultrasound test at the common iliac vein level should be about 15 millimeters on each side. She was 5 on the right and 3 on the left. So we think that she has a very severe compression at the iliac cable region. Can you see our X-ray or our fluoro?
So
we're going to
blow it up for everybody to see.
Yep. Tell me when you're ready.
Go ahead.
All right, so what you're seeing on the image is a bilateral injection at the femoral level, and the black dye flows through. We can see that on X-ray. The white area at the IVC level that I marked and over the common iliac vein level is more than likely the negative image of the aorta and the iliac arteries pushing into the vein. And so we actually have a very severe compression of the IVC, which I want to demonstrate with IVUS right now. You go ahead and expand the IVUS portion.
Go ahead. Go ahead. I've got it live.
Awesome. So we're going through the femoral vein now. Patient's been heparinized. This is the common femoral vein. We're in the external iliac vein, and we're driving through a tunnel. It's kind of like where we can see, as we drive through the tunnel, we can see, is there anything inside the vessel? Is there anything that's compressing the vessel? Spot me there. It stayed live on the X-ray. Can you see both images? Will?
Yep, we see.
Okay, so we're driving through the common iliac vein. The IVUS is starting to show a little bit of compression right there. And I can see right where the beginning of the compression is. So I'm going to go ahead and I'm going to go ahead and mark that spot so I know where the lesion is. Go live X-ray. We're going to continue to go through that compressed zone. Very compressed. I can feel it on the catheter as I'm pushing through. And we're getting into the vena cava now, and there's the artery right at 12 o'clock, still pushing on the vein, on the vena cava, and then it opens up to the vena cava. So she actually has a fairly high compression. This is probably through 2 to 3 centimeters above the level of the IVC juncture. And she's has obvious evidence of a venous obstruction because of this. So unfortunately, you can't really repair this particular lesion with a single stent. The stent will be too high and possibly compromise the right iliac venous system. So we're going to go ahead and IVUS the right side now to look at that area. Wendy was fast, and she actually got our measurements. If you can look on the IVUS, the pre-left common iliac vein measurement was about 90%, 89.5% obstructed. Now, the vena cava will also be one we'll measure, and we'll get that here shortly. All right, so here is the right side. We go live x-ray. And the external iliac vein looks to be pretty healthy. We're sliding along pretty well. We're in the common iliac level. And we definitely get some compression in that common iliac right there. And that's still because we're being obstructed at the vena cava level. So we always think of May-Thurner syndrome classically as obstruction of the left common iliac vein by the right common iliac artery. And in my experience with this, I would say that there's a very high rate of inferior vena cava obstruction or bilateral iliac vein reconstruction. Can you open stents, please, 16? Yeah, go ahead and do that. Pull back here. Okay. Will, do you have any questions?
No, I think this is a really interesting case, Chris. I mean,
Sweetheart, don't move.
I'll try not to.
You will. You can move all you want.
I think it's a really interesting case. I actually asked several of my colleagues to make sure I wasn't thinking wrong in the patient with Ehlers-Danlos that there would be a contraindication to putting a stent in the venous system. But I couldn't come up with one. None of my colleagues could as well. And so I think it's really a great case, great type of patient that we see almost every single day. And so I think you're right. She's got obstruction, it seems like, into the IVC. So I think going up that high is a reasonable thing. Sorry, I've been told to use a microphone. What's your plan on sizing, Chris?
So if you look at the image of the ultrasound on the screen right now, and if you look at the purple circle, when it says 80%, we are at 13 by 25 by 19, so that's 34 basically almost. So I divide that by 2. I get between 32 to 34. So 16 diameter stent is really the right size stent for this patient. Slide, please. And Will, the Ehlers-Danlos arterials, they have very fragile arterial systems. They make aneurysms, they rupture, they have significant bleeding issues. This hyperflexible variant is very different. You don't have major bleeding episodes with these patients. So far we've not had a negative outcome with the Ehlers-Danlos people with the hyperflexibility. Go left, please. And I think that their lack of collagen is really why they tend to collapse more readily. So I'm going to go ahead and start to deploy. I'm deploying the right side first. And you'll see this is a nitinol stent as well, made by BD, who are our prime sponsors for the conference. You can see that there's some compression still at that inferior vena cava level coming into that right side. We will need balloons, 14s.
I think it's really important to note that these stents are designed, built, FDA approved, indicated for exactly this purpose. And I always counsel patients, this is not something we're doing off the shelf or without indication, but they're designed and built to be in this specific location. They have a tremendous amount of what's called radial force. And so they're going to have to fight their entire life against the artery beating against it. So, these stents have only been on the shelf for 5-6 years, something like that.
Yeah.
And they're going to be in the patient for the rest of their life. But we're essentially reconstructing what we think should be normal venous anatomy. And that's why it works so well.
So this was a 90% lesion. Now, when Dr. May and Dr. Thurner did their original paper and described this, they described 2 main findings. One is that when the compression was there was damage to that vein, scar tissue that built up, synechiae that would build up inside of the vein. And I'm sure our sonographers have seen that before. The other thing is that they tend to have significant amount of collateral networks that have developed. And I'd like to go back to that original ultrasound real quick. The angiogram, the original venogram first. When we see, she actually doesn't have a tremendous amount. She's starting to get some late, especially on that left side. And some of the veins will come. Some of the veins we will see come either across pelvis this way, or you can get them, as you can see right here, that vein coming up. And so a lot of patients have pain in their back as sometimes one of their main complaints. And she does have a lot of problems with back pain.
And Chris, in my presentation forthcoming, it'll have a lot of pictures like that. So without your wonderful artwork, I'm sorry.
Sure.
So
no, I can erase all that. It's really easy. So we're going to go ahead, and because there's still a little bit of compression in that vena cava, we are going to do a little venoplasty there and make sure that that is opened optimally for her. All right. Yes,
you can see Chris has deployed the 2 stents, one coming from each side, and what he'll go in now is balloon on both sides with 2 big 14-millimeter balloons to kind of taper it out and make sure they're even on both sides. You have to remember these stents are 16 millimeters in diameter, so a typical cardiac stent is 3 millimeters in diameter. The stents I put in the arteries earlier today were 7 millimeters in diameter. These are obviously substantially larger, but that's the size of the system. You never want to undersize these stents. You don't want to have to go fishing in the heart for a stent later. That's bad form, and there's too much paperwork associated with it. So,
absolutely,
this is perfectly sized. This is well planned and everything else. So,
all right. So we're going to do a little venoplasty here. I'm going to go just that right side first. You kind of watch the vena cava at the top there. It's we're just trying to give this vein a little bit of support so that the stent can open optimally. And because we are moving things on the inside here, so you actually see that little move open. Can you take your side up? So sometimes that's just the artery just moving off the vein pretty quickly. Go live, please.
I'm at 1.
And we're just going to go easy. I'm at 1. I'm at 1. Okay, looks good. How's she doing? She's doing okay. You feel pressure? Okay. Slow. And come down. Okay. All right. Go live for me. Take that up to 2. Now, these stents, like Will was saying, are nickel titanium, and they will slowly dilate over the next couple of days to maximum size and body temperature. Come down. Let's do 10 straight.
Chris, that looks really great. What's your anticoagulation strategy for a patient like this?
Right now, we're on heparin for the procedure. Afterwards, I tend to use Xarelto 20 milligrams daily for 6 months, or Eliquis. I do a full anticoagulation. We don't have the data to tell us exactly what to do. Many of the people who do a lot of this work do the full anticoagulation regimen. I know we kind of have our internal study of Plavix versus Eliquis and Xarelto, and we don't know the answer right now. But I do think that there should do some form of anticoagulation for a period of time. The risk of DVT in this patients, the NIVL patients, the non-obstructive venous compression, or the non-thrombotic venous compression, you can do that for me, is very low. It's about a 2% chance. Do a run right here. Or do a completion venogram. Go. 1, 2. Nice.
It's beautiful.
Very nice. Yep. So everything's open. We'll finish with a quick little IVUS. Part of the job is to make sure that we're open from vena cava to the femoral level. And most of these patients will require pain medication for a couple of days, three to 6 days. So here's our left side. We're driving through now. Everything looks good. The stent's good.
So you can see the stent walls on the edge of the vein. That bright outline is the stent wall. So we're inside the vessel, inside the stent, and he's running catheter up there.
Yep.
And you can see there's no compression. So the stent's
Yep,
wide open. Before the vein was almost the catheter was almost completely occlusive within the side of this vessel.
And that vena cava is widely open now.
Yeah.
Which is what we want to see. And there's no obstruction on that side, and we're now exiting the patient. And so the femoral vein is fine. Sometimes you'll have to repair the femoral vein as well. There's 3 major zones of compression. The first is the common iliac vein. The second is the external iliac vein. And then as the venous system exits the pelvis, the inguinal ligament can sometimes constrict. Now, she actually has the 4th kind, which is the vena cava. So she really had a vena caval obstruction. And that's why we placed the stents as high as we did to fix this problem. All right, record that right there, full wire. All right, I think that's it. That looks great. Good technical result for our patient. She will be on full anticoagulation for 6 months. We plan to see them back at 4 weeks and 6 months to recheck everything. And then at that point, look for symptoms. I would expect, and I told her this ahead of time, that a lot of the pain, pressure, heaviness of the leg should leave. She does have a POTS condition with this, where she gets a lot of tachycardia anytime she walks. And part of that was that the venous return to the heart was compromised from the compression. So we saw the vena cava at the end of the procedure where it was widely open, and that hopefully that should resolve some of the POTS symptoms that she has. And then the IVC was 80% obstructed of the causing the obstruction in the case. Is there any questions, Will?
Any questions from the audience? I think it looks really great, Chris. So, yeah, again, they may have a little flank pain. It may put them out for a few days, but I saw her before I came over here. She wanted to go back to work Monday, and I don't have any objections. She might be a little sore, but,
Yeah, she may.
Yeah.
That's about the right size. It's usually about 3 days. But once that stent kind of settles, then the pain goes away and people can move back to their normal activities.
Agreed. All right, Chris,
All
get
right.
to your next case, and we'll see you back here in a little bit. Perfect. All right, so deep venous management, I mean, this is something that it's amazing how prevalent this is in the United States population. There have actually been cadaver studies where they looked at the rate of iliac venous compression in cadavers, and they found it in upwards of 1/3 of patients. And so it's there. We see it every day. If you see a typical CAT scan or a typical CT report, it's exceedingly rare that a radiologist would comment on it. But if you actually go back and look at CT scans, you see iliac venous compression all the time, and it's horribly undiagnosed. And we really only started looking for it in the last few years. Again, we classify these things into, when we're talking about deep venous disease, we talk about acute pathology like DVT, which for the purposes of this, we won't go into very much. And then we talk about chronic venous disease. And chronic venous disease is classified into non-thrombotic versus post-thrombotic obstructive disease. And they have kind of two different characterizations, but sometimes we think that non-thrombotic eventually can lead to a thrombotic type obstruction. You know, the narrowing of the vein can lead to deep venous thrombosis pathology. So you have to think that upwards of 25% of patients who present with deep venous thrombosis present with iliofemoral DVTs, and most of the time those are secondary to an iliac venous obstructive type pathology. And so it's a vicious circle, vicious cycle. And so in patients who have a hypercoagulable syndrome or are prone to DVTs or have had DVTs in the past, oftentimes this iliofemoral obstruction goes undiagnosed, and it's important to look for that on presentation. So this is a classic picture of a patient with fairly significant venous disease. How would you classify this from the SEEP score? Anybody in the crowd? So I would definitely say this is a CEAP 4 at the very, very least. It may be, if those are healed venous ulcers, that might be a CEAP 5. You kind of classify those scabs as ulceration, but definitely the skin changes are pretty marked. And so, like I said, a non-thrombotic lesion, like we were talking about, is commonly known as a May-Thurner type syndrome, where the right common iliac artery crosses over the left common iliac vein. First described in 1957, it results from the trauma of repeated pulsations on top of the vein. It creates subsequently, it can, in really bad cases, cause luminal webs within the vein. Sometimes we'll see that on IVUS. It looks like almost scar tissue in there. We see it most often in females and females who've been pregnant, so I allow women to blame their children as much as they like to. And we see it in males too, though. It presents just like any other venous disease would: heaviness, achiness, swelling, fatigue. Sometimes it causes significant varicosities. Sometimes it causes varicosities in the pelvis, labial varicosities, things like that. GYN providers may see it on physical exam, and that may lead to things like pelvic congestion syndrome type pathologies. And we'll touch on that in just a second. It can also present as restless leg syndrome, fatigue at the end of the day, and worst case scenario, deep venous thrombosis. Pelvic congestion syndrome or pelvic venous disorders are essentially where there's a delayed venous return out of the pelvis. And what it can be caused by is either the gonadal veins refluxing and the valves wearing out in those, or you can get an iliac venous obstruction causing impaired return of the flow outside the internal iliac veins into the common iliac veins and returning the blood flow back up to the heart through the inferior vena cava because of the obstruction and reflux. And so this can cause pain, heaviness, fatigue, painful intercourse, heavy periods. And so when you're doing a pelvic exam, if you're a primary care physician or provider and your patient presents with significant pelvic complaints, it's important to ask some of these questions and maybe do an ultrasound to further interrogate their pelvic venous anatomy to see if this might be a cause of their issue. I can't think that can't help but think that a lot of hysterectomies are performed every single year in which it might have been avoided with an appropriate pelvic venous workup. So the long-term effects of iliac venous obstruction can lead to the creation of collaterals. You know, Chris's squiggly lines that he drew on his IVUS images or on his fluoroscopy images earlier are better characterized by this actual fluoroscopic image, in which you've got a left common iliac vein coming up and there's an obstruction up top, and you get cross-filling of the lateral side of the right side through collaterals. And so the body has created these collaterals in attempts to drain the blood flow from the left leg and get adequate drainage. But they can oftentimes present this drastic, where they've had this unilateral swelling for years, they've had multiple DVT workups, and nobody's ever actually put an ultrasound probe above the inguinal ligament to see if there might be some sort of pathology up top. The reflux is caused, and this can lead to, it can be a vicious cycle and lead to superficial venous reflux, which can cause the valves in the veins to wear out, and we'll talk about superficial venous reflux later. But like Tina alluded to, when a patient presents with venous symptoms in our office, we do a workup above the inguinal ligament and below the inguinal ligament. So we look at the superficial venous disease, and we look at the iliac venous disease as well. In most patients, we treat the superficial system first, except in some, so there's no hard, fast rule. If they have significant iliac venous disease, venous obstruction, and they have a history of DVT or things like that, then oftentimes we will go after the iliac system first. Post-thrombotic syndrome is a devastating complication of deep venous thrombosis. That's why in the 21st century, I think referral to a vascular provider for evaluation for DVT is not optional, it should be mandated. The management of deep venous thrombosis has come a long way since putting them in the hospital, putting them on heparin drip, and putting on Coumadin, or rat poison, as you may see. Now we interrogate it, now we oftentimes will suck out the clot, but long-term clot staying in these veins can lead to the valves wearing out and cause chronic long-term swelling, and in a huge number of these patients, they will develop wounds. So how do we diagnose a patient who presents with iliac venous disease? Diagnosis, or history and physical is obviously first. CT angiography is one of the more classic ways of looking at it, but we also use ultrasound like Tina was alluding to. This is a good ultrasound performed in our office with a patient having a 3 millimeter diameter vein on the left side. Normal should be 12 to 14, and a 6 millimeter diameter vein on the right side. Again, this can be limited in patients with significant biscuit poisoning, and thus sometimes we have to use other means. High index of suspicion, common femoral reflux, or CT angiography with a venous phase contrast can be other adjuncts to looking at this. And the management, hopefully the patient doesn't get to this severe an issue where they get venous gangrene. I'm showing this to you right before lunch. But in a patient with severe symptoms, then a venogram is warranted with potential angioplasty and stent. So again, these stents, such as the Medtronic Abre and the BD Venovo stent, have revolutionized. The old stents that we used to use did not have an indication to be in the vein system for a long time. They originally had an indication to be in the tracheobronchial tree, but we've progressed, and these stents, along with great engineers, have allowed us to treat this with tremendous results. And so the rate of complications with these stents long term, I think it's really important. If you're going to put a foreign body into a patient, it's like a total joint. How long is this going to last me? What is the rate of complication? What are your overall issues? And the rate of major complications with these stents is overall less than 1%. Pretty spectacular. These procedures were all, in this study, all these procedures were performed in office-based labs such as ours. So how do we do this? How do we diagnose it? We do a venogram with intravascular ultrasound. You saw the images that Chris just presented. See the vein essentially pancakes around the IVUS catheter, and that's classic and diagnostic. And that's where the vein is crossing into underneath the compressing artery, which sits on top of the vein. And then we proceed with angioplasty and stent. This is an old venous stent in this image, but you saw Chris deploy a newer one in the post-IVUS video. This is another example of those cross-lateral fillings. You can see the, to give you an example, this is the right side, the patient's right side. This is the patient's left side. So all these collaterals are crossing the pelvis to drain the left leg into the right system. And this is post-op after we've placed a stent. Pretty spectacular. So I think it's, we alluded to pelvic congestion syndrome earlier being a symptom of patient with iliac venous obstruction. When we have a patient present with pelvic congestion syndrome, we look at their refluxing gonadal veins, but we also look at their iliac vein system. And I counsel them, if they're really, really young and they don't want a stent, then maybe we'll try and coil embolize their gonadal veins first. But in a lot of patients, we'll go straight to iliac venous stenting. And in upwards of 75% of patients with pelvic congestion type syndrome symptoms, a stent will alleviate almost the entirety of their symptoms. So I think that's important going in and can save the patient a lot of time and grief. And then a lot of these patients we put these stents into are young, right? And so they're of childbearing age, and they say, well, what if I have children going forward? And we haven't convinced anybody to do any double-blind randomized studies of putting in stents and say, go get pregnant. But that happens, and fortunately, a lot of patients have become pregnant afterwards, and the rate of complication is exceedingly low. And so I think that's important to know. I also tell patients it's a stent that I put in that I can't take out. Once it's in, it's there. We go based off their clinical history and whatnot. We think it'll help them, but in some patients it doesn't. We have to go down other avenues and look. So this is a patient who was 23 who had significant fatigue edema on their left leg. We went in, did an IVUS. This is kind of similar to what you just saw, and then put a stent in the left side only. Sometimes we reconstruct on both sides. We're finding more and more that we do it on both sides, and sometimes we have to do it on the right, just on the left side, for kind of the classic May-Thurner type syndrome. But you can see the post-IVUS, the stent was wide open. And we see it in the right side too. I think it's really important to look at both sides. This was a patient who you can see on the CT scan going down. The vein is, I can't do it from this angle, but the vein is coming down on the right side, and the external iliac on the right side, it was significantly narrowed, and I didn't need the CT to show me that. You can see the significant narrowing of the vein in that area. So I think it's important to recognize that the compression can be seen really on both sides. The stent patency of these stents is really, really good for the patients who are non-thrombotic, meaning they don't have a hypercoagulable disorder, they don't have a history of DVT, things like that. The patency is above 90 to 95%. The patients who are post-thrombotic have a lower patency, but often they have contributing factors. And the treatment efficacy is very, very good. They have almost complete relief of their pain, a long way out. This is an older study, and I think that now our data is going to be even better going forward. I'll fly through these studies really quick in the interest of lunch, but I think, you know, the patients who you want to proceed with a venogram on are those patients with significant venous claudication. They have evidence of iliac venous obstruction. Maybe they've failed superficial venous treatments in the past. You've done superficial venous treatments, and we'll go into those extensively later. But they've had recurrence of symptoms, or they've had persistent symptoms despite appropriate treatment of their superficial venous system. And then they may have, you know, pelvic symptoms or a significant impact to their quality of life. The nice thing is I don't really have to show you a lot of these images because Chris showed you such a great case earlier, but any questions before we break for lunch? Ma'am. Hemorrhoid problems? Yes. So I think we are starting to recognize that, that some patients will have hemorrhoid problems as well. We'll see testicular varices as well, lymphoceles in some of those patients. Not necessarily prostate problems in males, but yeah, I mean, it's sort of the same drainage system. So it's all venous. It's a really good question. Yes? You know, before I went into vascular surgery, I was a general surgeon, and I was really happy the last day I had to do a rectal exam. And so we relieve them as much as possible, but I think it is very poorly recognized in the surgical fields to look for iliac venous compression in those types of patients. And a lot of time the patient with hemorrhoid problems, with severe hemorrhoids, is looking for very quick relief. And sometimes that does dictate that they need a hemorrhoidectomy or something like that. But if we can relieve the pressure higher and decrease the amount of recurrence, because there is a fair amount of recurrence with hemorrhoid surgery, then I think that's we can work in concert with general surgeons. There's not been a great discourse between vascular surgeons and general surgeons as regard to that, or colorectal surgeons, but I think that has a huge amount of potential going forward. Or gastroenterologists for that means.
Is there a BMI cutoff for placing an iliac vein stent?
No. I mean, our tables are rated to 400 pounds or so. We don't have a BMI cutoff. Definitely you have an imaging problem. We have fluoroscopic tables that have a certain weight limit. And so that's probably the rate limiting step. And I think, in the patients with significant weight issues, high BMIs, the amount of relief they are going to get from an iliac venous stent is going to be somewhat limited, because I think there's a function of the weight to a certain extent. Now, in a patient with CEAP6 disease, CEAP5 and CEAP6 disease, then we'll throw the kitchen sink at them, and sometimes that will mean they'll be very heavy and we'll put a stent in. But for the most part, there's not really a fixed weight limit. We haven't had to do any cases at the zoo yet, so